Very pleased to have had the opportunity to come today and speak with you about insomnia. It's certainly something very common that affects many of us and the population. So today I'd like to cover definition and scope of insomnia, predisposing factors, and then how to diagnose and treat insomnia. We'll start with a couple of cases. The first individual is a 45-year-old male. His name is Jim, presents with difficulty falling asleep and staying asleep. The problem began after the death of his brother 2 months previously, and he's unable to fall asleep until at least about an hour after going to bed. He has no previous sleep problems. His physician noticed that he was having difficulty and started him on a low-dose tricyclic antidepressant for sedation as well as for a concern that he might have depression. But he wasn't able to tolerate it due to the anticholinergic side effects. He consumes 4 cups of coffee during the day and has recently began also using alcohol to try to get a better night's sleep. He doesn't snore or have any kicking or limb movement disorders, according to his wife. Our second case is a 40-year-old female. Judy is a school teacher, complains of inability to fall asleep for more than 2 years now. So while Jim couldn't fall asleep for a couple of months, now Judy's really had a hard time. She regularly goes to bed at 10 p.m., is unable to fall asleep until 1 a.m. She experiences about 3 awakenings per night, and each awakening she stays up about a half an hour. Has daytime fatigue, can't concentrate at work while she's trying to teach, and sometimes requires a nap during her lunch break. She vaguely recalls being involved in a stressful family dispute and doesn't remember very well, but thinks that maybe that's when her insomnia began. As bedtime approaches, she becomes very tense and worried at the prospect of another sleepless night. She does not take any sleeping pills, has no symptoms of depression, and when she goes on vacation or goes to sleep at someone else's house, she seems to sleep better. So Jim would be diagnosed according to the criteria as short-term insomnia disorder, which can times resolve, or it can progress and become a chronic insomnia disorder similar to what Judy has. Insomnia is defined as difficulty initiating sleep or maintaining sleep or waking up too early or sleep that is chronically non-restorative or poor quality. It occurs despite adequate opportunity to sleep. So you can't say, you know, I feel tired because I went to bed at 2 a.m. and woke up at 6 a.m. and I must have insomnia. You have to have the opportunity to sleep and adequate time to sleep, but despite that, feel unrefreshed or have disrupted sleep. And it needs to be accompanied by at least one of the following other symptoms. So obviously, many of us have felt this, have had firsthand experience, either fatigue, problems concentrating, social dysfunction at work or at school, irritability, daytime sleepiness, lack of motivation and energy, proneness to make mistakes and have accidents, can have headaches, feel anxiety, gastrointestinal symptoms, and concerns or worries about sleep. So it used to be more complicated a few years ago. Sleep and its insomnia diagnoses were broken up into several different types. But it was recognized over the last few years that insomnia can just be simplified to be classified as either a short-term insomnia, which is also known as acute insomnia or adjustment insomnia, and chronic insomnia. So short-term insomnia lasts a few days or weeks, usually per the definition less than 3 months. and it's a response to an identifiable stressor. Something acutely happened, as in Jim's case, his brother died, and this results in difficulty with sleep. The symptoms usually resolve when the stressor is eliminated or the individual adapts. Chronic insomnia is when the short-term insomnia continues and the person either isn't able to adapt or they have the formation of other maladaptive behaviors that then make the difficulty in sleep continue. And so it goes beyond 3 months, occurs at least 3 times per week, and usually is following the initiating stressful event. The precipitating event many times resolves, but the chronic course continues, and it's usually due to arousal, agitation, increase in muscle tone, all these maladaptive behaviors that result as a learned behavior over time. Commonly coexists with psychological or medical disorders, commonly depression, anxiety, or several common medical disorders. And many times it's very difficult to know which one came first, because as you would imagine, may have difficulty falling asleep because you're having pain, but then, you know, which one started first? Is it the pain that's causing the insomnia, or is it the insomnia that's exacerbating the pain? It's very hard to tell sometimes, especially after years of not being able to sleep very well. It's imperative we identify insomnia patients because it's very common in our society. And successful treatment usually involves treating both the underlying medical or psychological condition as well as the insomnia itself. And so treating both at the same time. When we look at insomnia in this country, 1/3 of American adults develop insomnia each year, about 33%, and so about 15 to 20% have short-term insomnia that resolves, and about 10% go on to have a chronic insomnia. It costs a lot of money. It costs the U.S. government more than $15 billion per year in healthcare costs. It costs our society and economy $63 billion annually. And 30% of overdoses usually involve medications that were prescribed for insomnia. So this is a big problem in our society. You might recognize some of these people. All of them claim to have had insomnia throughout periods of their lives. Abraham Lincoln used to keep his staff up until past midnight. And even then, he had a hard time going to sleep, and so he would go for walks in the middle of the night. Groucho Marx started having insomnia after the stock market crashed in 1929 when he lost a lot of money, and he continued to have insomnia after that stressful event. And Vincent van Gogh is been recorded to have used camphor, which is like turpentine, to soak his mattress to help him fall asleep. And so it's just very interesting what people do to get a good night's sleep. Here is a graph from the National Sleep Foundation that just shows what normal sleep time is when we're infants and as we grow throughout our lives. And you know, when we're full-grown adults, even if we're in our 70s, 80s, we're still required to have about 7 or 8 hours of sleep. But many people nowadays tend to have insomnia or just don't get enough sleep as it is. So when we have patients that come in, it's important, as in any good medical practice, to obtain a good history, perform a physical examination, and many times the physical examination is normal or the patient just generally appears tired, but sometimes can see other clues to other medical problems that may be exacerbating the insomnia, whether it's a hyperthyroid state or coronary artery disease or something else. Reviewing the patient's medications, obviously caffeine, tobacco, alcohol, prescription medications, and herbal medications. Alcohol is commonly used as self-medication to help treat insomnia. And what happens with alcohol is it's true that it will help induce sleep and make the person sleepy. But in addition to stimulating delta sleep, which is the deep sleep, it also inhibits REM sleep at the same time. And it also stimulates alpha waves, which are awakening waves that are happening in the brain. So once the delta sleep, the deep sleep stimulation goes away, the individual who's been drinking the night before is more likely to wake up, have arousals throughout the night, and also because REM has been suppressed in the beginning of the night, now REM rebounds and they tend to have vivid dreams, unusual dreams that are disturbing them throughout the rest of the night. Tobacco is also a stimulant, as is caffeine. There are screening tools. If you suspect someone might have insomnia and you're trying to find out what other contributing factors there may be, there are screening questionnaires for insomnia, depression, anxiety, sleep apnea. And then if we go further and suspect highly that the individual has insomnia, many times need to get more information and try to find out maybe some objective information in addition to the subjective information the individual is giving us. And so we give them a sleep diary, and I'll show you an example of that where they record their sleep and how it's going over the next 2 weeks. And then we also use actigraphy, which is a small watch-sized device that I'll show you. So this article back in the 1980s is kind of one of those landmark articles that's described insomnia in basically 3 phases. There's predisposing factors. So not everyone who has predisposing factors will develop insomnia. But it's been noted that older individuals, women more than men, psychological disorder history, substance use, living alone, and being a shift worker predisposes you to develop insomnia. Then there's some precipitating factor. It may be a medical condition or pain or a stressful life event that takes that predisposition that you have and causes the insomnia to emerge. And instead of having this insomnia wane and disappear over time, if there are perpetuating factors, then this insomnia will continue to cycle through for many months or years. And these could be cognitive issues where it's a learned behavior to start worrying about sleep, or behaviors that make sleep less desirable, such as napping or excessive time in bed, where the brain starts to associate lack of sleep with being in bed. And nowadays it's very common for us, especially with our devices, to be using our phones in bed, watching TV, reading, eating in bed. And for some people who are predisposed, doing other things in bed besides sleeping and sex winds up causing a learned behavior in the brain where the individual now learns to stay awake to do other things in bed rather than to sleep. So I usually start with a history, kind of asking the patient about the late evening, and I go through a 24-hour cycle. So I'll ask them, you know, what kind of problems are they having with their sleep? How long has it been? Is it at the beginning of the night? Do they fall asleep okay, but then wake up in the middle of the night? Why do they wake up? Are they having difficulty going back to sleep after they wake up? Are they having to go to the bathroom frequently? What things are they doing before they get into bed? Are they reading, watching TV? Is the room comfortable? All of these things are important to kind of get an understanding of what the person's home life is like. When is the bedtime? How long does it take you to fall asleep once you get into bed? And then what time do you wake up in the morning? How do you feel when you wake up? And is your final awakening time the time you get out of bed, or do you stay in bed longer after you've woken up? Then how's the day going? How do you feel in the morning when you wake up? Do you feel tired, or do you feel refreshed? How is your drive to work? Do you feel sleepy? How are you able to concentrate at work? Do you require a nap? How's your drive back home? Do you feel sleepy? Do you have to stop at the side of the road? And how is this affecting your mood, your family's life? Then we go over medications. It's not something we think about much, but many common medication types will cause insomnia. And so you can see antihypertensive medications, which many individuals are on, bronchodilators, hormonal therapies, antibiotics, antidepressants, anticonvulsants, many common medications that we prescribe every day. Here's a sample of 1 page of a sleep diary. Usually it'll record about two weeks worth of information. And if you look up sleep diary on the internet, there's so many examples. You can print them out in PDF form. And they're usually in this format. They're broken down into one section that you complete in the morning and one that you complete at bedtime. The one you complete in the morning asks you questions about how the night went. And then you go through your day, and the questions that you complete at night ask you how your day went. And so they ask you about the time you fell asleep last night, how was your sleep, what time did you wake up, and then how your day went, and how did you feel throughout the day, and then any other activities that you might have had throughout the day. In addition, to get some objective information, we'll also issue patient an actigraph, which is this watch. It basically, excuse me, just measures light, and it measures vibrations or wrist movements. And you can see here in this example that these lines are all the wrist movements that are happening throughout the day. And then as the individual goes to sleep, they don't move as much, and so there are few scattered lines, but not very significant compared to the daytime awakening. And you can see from day to day how many hours the individual is sleeping, when is their sleep onset time, when do they wake up in the morning, and it gives a very nice demonstration of information. Sometimes this matches what the individual is telling you, sometimes it doesn't. Sometimes they have an unrealistic understanding of their sleep. They think they're sleeping much less than what the actigraph shows. Now, this doesn't directly measure sleep. It just measures wrist movements, but we can assume from these quiescent periods that the individual is asleep. Now, polysomnography, while you think it would be a great way to study sleep, is really not a good one for insomnia. And the reason for this is because if you've ever had a polysomnogram, you go in, they put a bunch of sticky wires on your scalp, and you're sleeping in a unusual location, and they come in and wake you up. And so it's really not a good study for insomnia. But it can be indicated if the individual appears to be waking up in the middle of the night and it's not clear why. They may be having apnea or leg movements that are causing them to wake up, and then all they can tell you is they wake up for some reason, they don't know why, and then they have a difficulty falling asleep. And so as a trigger for the arousals, if nothing else is found, it's important to do a polysomnogram to look for other underlying sleep causes. I like this cartoon, and no wonder you have insomnia lying there awake all night. So she's not being very helpful in her treatment, but there are 2 treatments that are helpful, and we'll be talking about pharmacological therapy as well as cognitive behavioral therapy, which really over the last few years has emerged as the main method for treating chronic insomnia. So with short-term insomnia, like our first patient, many patients, before even coming to a doctor, try over-the-counter sleep aids and possibly alcohol before they see their doctor. And when they see their doctor, it's important to go over with them sleep hygiene tips. Again, if you type in sleep hygiene into the internet, you'll see very similar recommendations to what we'll be going over soon. If they're really having a hard time functioning throughout the day in their work, or really it's a severe case, it's possible to use a hypnotic agent, prescribe a non-benzodiazepine hypnotic to them. But the goal is to monitor these patients closely and to see them back soon and see how they're doing. And if they're able to tell you that they're doing better and they're sleeping better, to start to wean off the medication over the course of the next few weeks. And it's important because if these symptoms continue for months, it may progress to a chronic insomnia, which we're trying to avoid. With short-term insomnia, it's important to discuss, what other potential anxieties, stressors the individual has. Are they adapting, or is it possible that they're having maladaptive behaviors forming? Here is a diagram of just the wake-promoting neurotransmitters that we're familiar with. You may not have been as familiar with the last one, which is orexin or hypocretin. This neurotransmitter was discovered in the late 1990s by 2 independent laboratories, and that's why it has 2 different names. And it is missing in patients with narcolepsy with cataplexy. And so patients that have narcolepsy and tend to fall asleep very easily are missing orexin or hypocretin. And it's also involved with appetite regulation. The reason I mention it is because, as you'll see in a couple of slides, there are now medications that affect this pathway. Now there are inhibitory neurotransmitters that help us go to sleep, and we're all familiar with GABA receptors. This is what the benzodiazepines stimulate. It's a pentad in structure and has various subunits. And then also melatonin, which is secreted in the pineal gland soon after darkness sets in the evening, and it also has a hypnotic effect. So here are the various classes of sleep medications approved by the FDA that are available to us today. As you can see, benzodiazepines, they, depending on the medication, have different elimination half-lives. And then all the way to the right, SOI stands for sleep onset insomnia, and then sleep maintenance insomnia. And so the medications that have longer half-lives are used for not only to help someone fall asleep, but because the medication lasts longer, it helps them to stay asleep, versus medications with shorter half-lives that are mainly meant to help someone fall asleep, and then the effect wears off. Benzodiazepines, because of their respiratory depressive effects and also the higher chance of becoming dependent on them, are not used often for insomnia treatment during the current times. And we have newer medications which also stimulate the benzodiazepine or GABA receptors, but they are not benzodiazepines in structures. And these are commonly referred to affectionately as the Z drugs. And so Zolpidem is a short-acting medication. I think everyone's familiar with Zolpidem, which is Ambien. And then there's a formulation of Zolpidem that's a CR that's coded to release acutely and then more slowly and make it last longer throughout the night for sleep onset and sleep maintenance. And then isopiclone, which is Lunesta, also has a longer half-life for sleep onset and sleep maintenance. In addition, we talked about melatonin, and so there's a melatonin agonist now, Ramelteon, that is also indicated for sleep onset. There's histamine antagonists, and because we said histamine was one of those stimulatory neurotransmitters, doxepin is an antagonist that's for sleep maintenance. And then a new class of medications that are actually orexin antagonists. Suvorexant is a medication we've had now for several years, and just a few months ago in December, a new medication was approved by the FDA, lemborexant, which is again in this class as a orexin antagonist. Now, if we look at these Zolpidem, just because it's one of the first medications that came out, Ambien, and it's most commonly known, Ambien itself also comes in other formulations now that can be ordered. There's sublingual forms, and these as well as an oral spray. And these can be used especially for individuals that have a hard time swallowing. And the sublingual, it's like a film that can be put on under the tongue. It's for sleep onset insomnia in low doses because it's going to last throughout the night. And then there's a smaller dose formulation that's used for sleep maintenance insomnia. If someone wakes up in the middle of the night, it can be used there to help them fall back asleep. It was discovered after Zolpidem was released to the public that high blood levels can maintain 8 hours after ingestion, and this differs in men versus women in the metabolism. And so women tend to have higher drug levels even 8 hours later compared to men. And with that information, now you'll see when you look up Zolpidem or Ambien that it recommends half the dose for women compared to men, which is interesting. Whenever you look up a medication, you usually don't see dosing based off of the sex of the patient. Other off-label medications that are not FDA approved but are helpful are sedating antidepressants, so trazodone, amitriptyline, sedating antipsychotics, especially quetiapine, antihistamines, which are common in many over-the-counter formulations, and then gabapentin as an anticonvulsant. These can be helpful, especially in patients who have comorbid conditions. So if they have comorbid depression or schizophrenia, bipolar disorder, if they have seizures or neuropathy, gabapentin can be helpful. And then antihistamines, especially if they have seasonal allergies. The goal is, again, to just be careful with the half-life because some of these medications can have longer effects that will last into the morning. So in addition to medical therapy, what has emerged as really the best therapy for chronic and long-term insomnia over the years is cognitive behavioral therapy for insomnia, or CBT-I. Structural treatment utilizing behavior strategies that are usually administered by a sleep coach, usually a psychologist or specially trained individual who meets with the patient about an hour a week for a couple of months. And they go through and discuss what it is that's affecting them and what behavioral changes and thought changes that need to be made as they talk through some of the problems that are resulting in this perpetuation of their chronic insomnia. Unfortunately, it's only currently used in about 1% of patients with chronic insomnia. It's not only under-recognized, but it's more difficult to treat patients this way because of insurance coverage and lack of awareness. But the benefits appear to last over 2 years. And it's similar to that analogy where instead of giving a man a fish, to teach them to fish, to learn on their own how to fall asleep is a much better and long-lasting therapy. So CBT-I is kind of a collection of various therapies. The ones that have been shown to be most effective are the first 3 we'll talk about, and then the last 2 are adjunctive treatments. So sleep hygiene education, I already alluded to that. We'll go through and explain in the next slide what that usually entails. Stimulus control therapy, sleep restriction therapy, and then in addition to that, many times the psychologists will go through cognitive therapy to discuss what things and maladaptive thoughts the person may be having, as well as relaxation training. So sleep hygiene instructions basically are just to have better hygiene, in your sleep. And so these steps are very commonly found and are very similar when you look them up. Sleep only as much as you need to feel refreshed. So don't stay in bed too long if you're awake. Get up at the same time each day, 7 days a week. Now, if someone isn't having a problem sleeping or having a problem with insomnia, these don't necessarily apply. They seem very excessive. But for individuals that are very sensitive to their sleep and have a lot of variability, need to gain more control over the regimen of their sleep. Exercise regularly, but try not to exercise within 3 hours of bedtime, because that can sometimes increase the body temperature and muscle tension. Maintain a comfortable bedroom. Avoid heavy meals close to bedtime, but also don't go to sleep hungry, because if you have hunger pains, it's difficult to fall asleep. Avoid excessive liquids, cutting down on caffeinated products, alcohol, smoking. Avoid napping throughout the day. Don't take your problems to bed. So many times setting a time an hour before where you can sit down, talk through the day's stressors, maybe with a spouse or friend, and then also having a pad of paper next to your bed. If a thought comes to you in the middle of the night, being able to write it down and leave it there, knowing that you're not going to forget it when you wake up in the morning. Also turning the clock away from the individual so that if they're awake, they're not constantly looking at the clock and becoming frustrated by the time. The second type of therapy is called stimulus control therapy. And this is basically targeting the fact that the bed should be for sleep and not for reading or watching TV or anything else. And so what happens here is because the individual has now formed associations between what they spend time in bed doing and difficulty with sleep, you need to get the patient out of bed when they're not asleep. And so At bedtime, if they don't fall asleep within 15-20 minutes, they're instructed to get up, go to another quiet room, maybe under dim lighting, start reading a book, or just you know, try to concentrate or meditate until they become very sleepy, and then go back to bed. If again, after 15-20 minutes, they're still not able to go to sleep, get up again, leave the bedroom, and go sit somewhere else until you're sleepy again. That necessarily means that, okay, well, if I keep doing that 2 or 3 times a night, I'm probably going to have a hard time waking up in the morning. And that's true. It's going to be more difficult. But as the individual keeps doing this night after night, they start to retrain their mind that they're only going to stay in bed when they're sleepy and not lie there staring at the ceiling in the darkness, getting more and more frustrated by their lack of sleep. Sleep restriction therapy is the third type of therapy, and this one aims to reduce the time in bed until it becomes efficient. And so if we take the time in bed and divide it by, take the time asleep and divide it by the time in bed, we get a percentage of how much time we're sleeping compared to how much time we are in bed. And so if you go to sleep at 10 p.m. and wake up at 6 a.m., that's 8 hours. But if you go to bed at 10 a.m. and don't fall asleep until midnight, then from midnight to 6 is 6 hours, but you were in bed 8 hours. So your sleep efficiency is 75%. So based on the individual's diary that they filled out, the goal is to make sure that their sleep efficiency is over 85%. And so not to go to bed and stay awake, they need to get up out of bed as in the previous therapy. But in this case, you're preemptively trying to reduce their unfruitful time in bed. And so you would then instruct the individual, you're only sleeping 6 hours, so no use in going to bed at 10 p.m. We're going to instruct you now to go to bed at 12, but then wake up at 6 a.m. every morning, even on the weekends, to an alarm. And then that time becomes much more efficient. The time you're going in bed is primarily composed of the time you're asleep. And as their sleep time becomes more efficient, then the therapist starts adding 15 minutes to the front end, to the time that they go to bed, allowing them more and more time to sleep, as long as that efficiency stays above 85%. If they start to drop off and they start having a hard time, then they shorten the time again until the individual has a good sleep efficiency. In addition, there are some adjunctive therapies, relaxation therapy, meditation, guided imagery, as well as cognitive therapies where the individual is encouraged to talk about what it is, what kind of anxiety feelings they're feeling before they go to bed, and help them with maladaptive thoughts or difficulties with fear about falling asleep. So if we compare CBT-I versus Hypnotics, there are some advantages and disadvantages. CBT-I is equally effective in the short term. It's superior in the long term as far as efficacy. It has minimal side effects, and some patients prefer not to have to take prescription drugs, and provides lifelong skills. Its disadvantages is it requires many times insurance reimbursement. You need to have qualified providers, which are in short supply. Delay in therapeutic response compared to medication. Some people want a quick fix, and it requires discipline and perseverance. Hypnotics, on the other hand, have a speedy response, easily available, minimal patient burden, just take the pill. But there's a risk of dependence and other side effects. What about combining the two? Well, it's possible. There aren't many clear conclusions from studies to show that it's superior over CBT-I alone, but it can be used in combination, especially if individuals are really suffering. And in order to undergo their CBT-I, they need to have a few nights of good sleep in order to be able to concentrate and be in a good enough mood to start their therapy. And so they can be combined for very difficult to treat patients. Here's a study, Annals of Internal Medicine, which was a systematic review and meta-analysis. They looked at 20 randomized controlled trials, and they looked at 4 basic sleep measures. The sleep onset latency is the time when you go to bed to how long it takes you to fall asleep. The WASO, or wake after sleep onset, is how many times you wake up after you've been asleep and how many minutes you are awake. The total sleep time, and the sleep efficiency, which we just talked about. And they measured, they looked at these studies, and they looked at the benefit of CBT-I immediately after completion of the 6 to 8 weeks of therapy, and then measured again from 1 to 6 months, and then from 6 to 12 months. And you can see here, all the studies are mentioned here, and they're very small print, but you can see here the diamond that pretty much sums up all of these studies is on the left side of the line indicating benefit with CBT-I in sleep onset latency. This is right after the therapy. Unfortunately, as the time went on to look at 6 months and then a year, the number of studies that went that long decreased. And so with the number of patients decreasing, we couldn't show a confidence interval tight enough to continue to show that response. And then this is from 6 months to a year. Here again, this is wake after sleep onset, improved. And again, as time went on, the number of studies decreased, and they couldn't show that it maintained. Even though in these studies, it appeared that they were beneficial, but the total number of patients weren't large enough to demonstrate having the diamond on one side of the line. Here, total sleep time. Again, there was improvement, as well as the sleep efficiency showing benefit. And so in this study, when they cited other references that had normal values, they showed that sleep onset latency was usually 35 minutes or less. Wake after sleep onset was 40 minutes. Total sleep time 439 minutes, and sleep efficiency 80 to 90%. The sleep onset latency in their insomnia groups, in the 20 studies they had, took 58 minutes to fall asleep compared to 35. But after CBT-I, this decreased from 58 to 39. Wake after sleep onset, there were 76 minutes they were awake, which reduced to 50 minutes. Total sleep time also increased, and then also the sleep efficiency increased from 72% to 82%. About internet-based CBT-I. So this was another review of 15 randomized controlled trials where they looked at 1,013 patients in the experimental group, plus another 591 patients who were waiting to get into their therapy. They weren't even in therapy yet. And again, this was right after the therapy was completed. Some were receiving internet-based CBT-I as they were waiting to get into their in-person groups, while others were receiving internet-based CBT-I while they were receiving in-person visits as well. And both of these groups benefited from CBT-I that was done over a computer, showing improvement in the 4 measures that we discussed earlier. Mobile phone interventions. This study, as you can see, started measuring or had a compilation of studies that began in 1983 all the way till 2016. And you might wonder, well, mobile phones back then didn't do very much in the 1980s compared to the ones we have today. And so they actually had conventional therapy. They would call the individual over the phone just to talk to them. And then some of these studies went on to texting, just to check up on the patient as an adjunct to their clinic visits, and then the emergence of phone applications that we have today, which are standalone and many times to help deliver therapy as well. And 14 out of 16 studies showed that traditional therapy over a phone was helpful, as well as telephone-supported interventions such as texting or calling to check on the patient, as well as helping patients who are on a wait list awaiting conventional therapy. This is an app that's available today. You can download it. It's free, and it's for Android and Apple devices. It was created by the Veterans Administration and Stanford University, also with funding from the Department of Defense. And it's a very nice application. There are other applications in the app stores, but many of them require like a monthly fee or subscription. And this one has been studied and is actually effective. But you can see here it has multiple alarms to kind of remind you, you know, to take your time out to kind of try to meditate and think about your day, what time to go to sleep, what time to wake up, your sleep environment. It has videos to help you with breathing, to help you slow down your breathing, to progressive muscle relaxation. It's just a wonderful resource that you can use to help. Again, it requires some effort on the individual's part. It's more training than what a pill would require, but at the same time, it's free and it's helpful in developing the right tools and overcoming maladaptive behaviors. This study shows a survey of VA personnel that started using the device. Basically, the psychologists who were working with patients, and they found beneficial effects regarding dropout rates, patients doing their homework when they go for in-person therapy. The app helped them to continue to practice things at home, and also reduce the amount of non-compliance. So CBT-I online versus attending a class. CBT-I online is available for everyone with an internet connection. Individuals can work on it on their own schedule, especially if they have a tight schedule. Can be just as effective as traditional therapy if someone's self-motivated, and it's definitely less expensive. But when it's been studied, there is a higher dropout rate with self-motivated CBT-I over the internet versus actually seeing a person. And you can see that there are significant dropout rates either way. Not everyone sticks with this kind of therapy, even if they're seeing a therapist in person, but this is worse with over the internet therapies or online therapies. And then you also have the potential of detecting other medical problems or depression, anxiety that the apps don't necessarily pick up on. So in summary, insomnia is common in our society, as we all know, often associated with and exacerbates medical conditions, psychological conditions, and those conditions can affect the insomnia and worsen that. It's associated with increased morbidity and mortality, and short-term insomnia may require pharmacological therapy and close follow-up to make sure it doesn't progress into chronic insomnia. If chronic insomnia develops and the individual has those maladaptive behaviors and thoughts, then CBT-I is the preferred treatment for patients with chronic insomnia. All right, open up Thank you
much. Thank you very much. We do have a little bit of time for questions here, and I'm going to run up over here.
Thank you for the presentation. What about restless leg syndrome? What have you found effective for that as far as sleep insomnia therapy?
That's a wonderful question. Yeah, restless leg syndrome is a diagnosis that's really a clinical diagnosis, and it involves the feeling of a creepy crawly kind of ant-like feeling crawling up your legs, or tension in the legs that tends to happen more in the evening. It's a circadian involvement that tends to affect people more at the time before they go to bed. Once they fall asleep, restless leg syndrome can't be made as a diagnosis. It actually tends to stimulate periodic limb movements in sleep. And so when we do a polysomnogram, we're looking for periodic limb movements in sleep that could awaken a person from sleep. But restless leg syndrome is what's happening before the person falls asleep. And so as you are probably asking, it contributes to insomnia because the individual has a hard time falling asleep. There are various therapies that are effective. It tends to be more common in women than in men. It tends to run in families, and sometimes the mother will have it and the daughters will have it. And there are some relaxation techniques, yoga, stretching, warm baths that may help some individuals. But there are primarily medical therapies that are helpful. And so medications that are most commonly used nowadays are medications that are used for Parkinson's disease. And these medications have also been found in lower doses to help with restless legs. We can mask it with narcotics or benzodiazepines, which isn't really recommended as much anymore. And then there's also anti-seizure medications, especially gabapentin, that can be helpful. But in general, it's common in many patients coexists with kidney failure, with thyroid disorders, with pregnancy. And it's been associated with low ferritin levels, low iron storage in the blood. And so before we start anyone on medical therapy, we always check a ferritin level. And if the ferritin level is below 50, we start the individual on iron replacement, because many times just taking iron will help resolve the restless leg syndrome.
Another question right here.
Thank you for that presentation. I've heard that Ambien can be related to Alzheimer's. I've read that. I was wondering if there's any research. Have you heard that?
Yes, I haven't. That's a good question. I think it'd be helpful for me to go and search for that as well. As you know, Ambien and many of the Z drugs, have been associated with nocturnal behaviors. Some individuals going and mowing their lawn in the middle of the night, or going out and driving. And these are things. Even I had Roseanne Barr's picture up there. Even she actually I think had tweeted a racial tweet and then blamed it on her Ambien. So there are various behaviors that happen in the short term. As far as Alzheimer's, I'm not aware of the data on that. Yeah, that's true.
Yeah, this is kind of a follow-up question, because I've looked at some of the studies that showed the adverse health outcomes of these sleep aids, and endpoints such as things like even like cancer and heart disease. Now, it's hard to know because, it's the chicken or egg question.
Right.
Is it because these people are developing, they have chronic conditions and as a result they have a hard time sleeping and then they get on these sleep aids? Or is it the fact that they have a hard time sleeping, they get on the sleep aids and then develop some of these medical conditions such as cancer? And so I was curious, I was going to follow up with that. Have you looked at any of the studies there? Because it seems to be a lot of population studies showing association, but nothing yet that I've seen in terms of a randomized controlled trial or nothing that I've seen that kind of teases that out, whether it's causation or correlation.
Yeah, that's a great point. And yeah, it is very difficult because just lack of sleep or short sleep is associated with coronary artery disease, with cancer. Many, studies on shift workers also demonstrate higher rates. And so it's very difficult to tease out whether, it's just the medical condition itself or exacerbated by poor sleep on top of that, and then if there's even an additional effect of sleep medications on top of that. So short of having randomized controlled trials, which is difficult in these long-term types of scenarios, it's hard to say. It's mainly, a lot of times a association, but doesn't necessarily mean a causation effect. So that's why a lot of individuals prefer not to take medications or prefer to learn how to sleep better without just taking hypnotics.
Several questions, one here, then a few over here.
Mm-hmm.
When your body gets out of the cycle of the sleep cycle that you normally have, let's say 6 to 8 hours, through interruption over a period of time, how difficult is it to get back into a regular cycle of 6 to 8 hours of sleep?
Yeah, it is. It does require some training, and it requires that the individual really take time to go through and make sure their sleep hygiene is appropriate, and then if they need additional assistance with going through CBT-I, it takes several weeks to do that, but it's just like anything else. It's something you learn and you get better at, and with time, the individual starts to sleep better. I remember reading about one lady who'd had insomnia for many years and was taking a medication to help her fall asleep, and her doctor tried to get her off the medication, and she was trying to come off of it, and finally he tried to stop the medication. She said, "No, I don't want you to stop it. As long as I just lick the pill at night, I feel like it helps me go to sleep." And it just demonstrates that a lot of times these are learned behaviors. She wasn't getting really a significant amount of medication in her system to do any good, but just the fact that she believed it was helping her fall asleep was effective for her. And so I think a lot of times these learned behaviors take time to resolve, and it requires some counseling and learning how to sleep again.
Another question to your left.
You mentioned doxepin and trazodone low dose for sleep aids. Have you ever used Remeron for that?
Yes, yeah, and Remeron is also helpful and it's effective, and it has less addictive potential as well. Oh, just reduced Remeron. Oh, I was just saying it has less potential for addiction than like benzodiazepines.
Go ahead.
Generally, you don't like to suggest naps, but is there any time when a nap is necessary?
Yes. That's, again, a great question. So there are times when nap is very helpful. So if someone has a chronic problem with sleep, a chronic insomnia, and they're having difficulty throughout the day. You really want to avoid the naps in these individuals because it reduces the drive to sleep and makes it more difficult for them to sleep at night. Where naps can be very helpful is if someone has short-term insomnia, or they're a shift worker, and or many of our residents that are working overnight and need to continue to work throughout the day. We have our circadian system, which is our alerting system, and it's referred to as process C. And then process S is our other system that's trying to put us to sleep as we go throughout the day. And these two are pulling each other like a tug of war. The circadian system is what keeps us awake, but it has two phases, and around 1 to 2 o'clock in the afternoon, it dips, and that's why many times we get sleepy in the afternoon after lunch, and then it picks back up again and does its job for the rest of the evening. And so if someone really didn't get a good night's sleep, taking a nap, restricting it to about 20 to 30 minutes, setting an alarm, and taking that nap during that dip in the circadian phase will often result in them feeling refreshed and able to continue the rest of the day. And so having that nap planned and able to do it only if they've lost a significant amount of sleep the night before can be very beneficial.
Thank you.
Mm-hmm.
Next question up here.
Do you see cases of person being sleepy, so they drag themselves to bed, and as soon as the lights are turned out, they actually wake up?
Yeah.
And what do you do for them?
Yes,
and the next question is, some years back, I read an article about cancer association with Ambien. Have you seen confirmation studies?
Yeah, and to answer the last question, I haven't. Again, I think it's hard to prove that at this point. Obviously, it's one of the most commonly used medications for sleep. I haven't seen any conclusive studies on that, but certainly I think, like you mentioned and others mentioned, there are concerns with associations due to lack of sleep, but it's hard to say at this point. What you asked initially is a perfect description of what happens with chronic insomnia, where the individual will fall asleep on a couch, but then they wake up and try to go to their own bed, and then they're wide awake. And many times, just like the description in our second case, where the lady could fall asleep more easily on vacation than she does at home, again, because you have that learned association with falling asleep or the maladaptive thoughts of falling asleep in your own bed, you're able to fall asleep somewhere else, but once you get into bed, you're wide awake. And so by taking part in cognitive behavioral therapy and getting up out of bed when you're not sleepy and only going back to sleep when you're really drowsy, and maybe having to do that 2 or 3 times during the night before you fall asleep, it retrains the mind to fall asleep in the bed again.
We have time for maybe about 3 more questions. One in the back, one up here, and one back here.
Can you comment on the side effects of long-term use of sleep aids, specifically Ambien or melatonin? Does your body become dependent on those, and are there side effects?
Yeah, with melatonin, so far it hasn't been found to be where you develop a dependence or resistance to it. The Academy of Sleep Medicine doesn't find enough evidence, especially because melatonin is not regulated. It's over the counter. It comes in different doses. Don't know what formulations the various companies are using. And so the statement by the Academy of Sleep Medicine really couldn't say that melatonin is a definite over-the-counter medication to use. And that's why there's the melatonin agonist that I mentioned that is FDA approved, but as far as melatonin itself, as far as its efficacy, the data isn't very strong. But some people find benefit from it, and I'm sure it works in some individuals. As far as Ambien and the other benzodiazepine agonists, those have been studied up to 6 months and haven't found to have a statistically significant level of dependence like benzodiazepines would. So all those Z drugs certainly appear to be safer as far as dependence from compared to benzodiazepines. But again, they're not recommended for long-term use for chronic insomnia indefinitely. And currently, many patients are just on medications that I've been taking for years. And as I mentioned in the slide, CBT-I is used in about 1% of patients with insomnia.
Another question over here to your right.
I often get stuck on a red-eye flight out of LAX to the East Coast. Find myself taking several days to get back in a sleep routine. What do you have for jet lag?
Yeah, so great question. And so there's a saying, when you travel east versus west, east is least and west is best. And so when you go east, you're going to have a hard time adjusting because everyone else wants to go to sleep sooner than you do, and it's hard to make ourselves go to sleep earlier. When we come back west, even after we've adapted to the circadian times on the East Coast, we're able to we can make ourselves stay up later and go to bed later, and then it's easier to just stay asleep later into the morning. And so especially when you're going east, where it's going to be harder for you to adjust when you get there, again, sleep aids can be helpful. And so some people benefit from melatonin, some people need sleeping medications to help them fall asleep, but it's going to be more important for you, and you can try melatonin, 3 to 5 milligrams. Again, the evidence behind it isn't strong enough, especially because of the variability in dosing and the non-standardization of it. But there are some articles that show benefit with taking melatonin when you go east to help you fall asleep sooner. And turning off the lights early, too, to stimulate your own melatonin to be secreted sooner.
One last question up in the back.
Sure. I just would like your comment on something that I've tried occasionally, and that is talking to people who just can't get to sleep. Tell them to get up and then do something really necessary but boring. Balance a checkbook.
Yeah.
The idea is don't read an exciting book because then they'll stay up all night. But number one, they'll get tired and they'll probably want to go to sleep at that point. But number two, if they don't go to sleep, at least they got something useful done. Because one of the things I've had people complain about is that they're really worried that they're not going to get enough sleep and they're going to be no good tomorrow, and they've got to get to sleep, and of course that anxiety just makes it worse.
That's a great point, and it's going to depend on the individual. Some people, the balancing the checkbook may be boring and put them to sleep. Others, they may get so frustrated by it they'll stay awake. So each one needs to find what it is that they can do to help them fall asleep. But I think that's a great tip.
Thank you very much, Dr. Fargo. Let's give him a round of applause. We appreciate that.